So today we're going to be talking about a carotid cavernous fistula, CC fistula. A fistula is abnormal connection between two unlike things, and in this case it's between the carotid artery, either the internal or external carotid artery, and the cavernous sinus. So it is a form of an arteriovenous fistula. The artery is the carotid, the vein is the venous sinus called the cavernous sinus, and the fistula means arterialized blood is going to be traveling into the slow flow venous side without any intervening capillary bed. So as you remember from anatomy, the anatomy of the cavernous sinus here in coronal section, in the wall of the dura of the cavernous sinus, it relatively protected our cranial nerves 3, 4, and 5, subdivision 1. In the posterior cavernous sinus, we'll have V2, but V3 has already left. Doesn't go into the cavernous sinus and goes out the foraminal valley. This is the internal carotid artery, and 6 lives free-floating in the substance of the cavernous sinus. And so cranial nerve 6 is often involved in patients who have carotid cavernous fistulas. And surrounding the internal carotid artery, and or jumping for a short course on 6, is the ocular sympathetic pathway, and so we may or may not have pupil involvement from the Horner syndrome and an anisocoria that's greater in the dark. So when we have a carotid cavernous fistula, the key and differentiating features are the presence of the multiple cranial neuropathies, plus or minus the Horner syndrome from the cavernous sinus involvement, and because it's a vascular lesion from the carotid, either the internal carotid artery or the external carotid artery or both, the flow will be directed retrograde and anteriorly into the orbit, and that means the superior ophthalmic vein might be dilated. So if we have a carotid cavernous fistula, the blood, instead of going from the orbit to the cavernous sinus and back down the petrosal to the jugular, the blood is going anteriorly, and that's going to produce an enlarged superior ophthalmic vein. And the enlargement of the superior ophthalmic vein represents the retrograde flow of the arterialized blood into the orbit. And what that is going to produce is the key and differentiating features of carotid cavernous fistula if the blood is draining anteriorly. So the cornea here, the blood vessels might be dilated, the episcleral blood vessels, they'll be dilated and tortuous to the limbus, and they might loop back. The intervening conjunctiva is often clear, and it forms these alternating omega loops like the Greek letter omega, omega, because the dilation and the tortuosity make the vessel dilated and tortuous, and that we call arterialization. This arterialization of flow is the distinctive finding. In addition, it might cause increase in episcleral pressure, which would cause glaucoma, so the elevation of the intraocular pressure may occur. There may be retinal venous dilation, a macular edema, and retinal hemorrhages. It might even be a central retinal vein occlusion, or they might have ischemia to the optic nerve. So we can have problems both on the afferent side, loss of vision, ischemic optic neuropathy, macular edema, central retinal vein occlusion, and on the efferent side, cranial nerves 3, 4, 6, and pupil problems, big pupil from the third nerve palsy, small pupil from the Horner syndrome, and we're going to have a dilated superior ophthalmic vein radiographically. The patient will be proptotic, ophthalmoplegic, complaining about diplopia. So when we have a carotid cavernous fistula, we can either have a direct fistula, a direct tear in the internal carotid artery, that's normally from trauma, and that is a type A fistula. Or it can be a low flow fistula. A low flow fistula is indirect fistula. It's non-traumatic, often spontaneous in older middle-aged people. And the low flow fistulas are either from the internal, external carotid, or both, which are the classifications B, C, and D. So the B, C, and D fistulas are the low flow, non-traumatic fistulas from either branches of the internal or external carotid artery, and the only way to know that is to do an angiogram. So in any patient who presents with orbital signs, proptosis, arterialization of the conjunctiva, diplopia, afferent and efferent problems, or evidence of cavernous sinus involvement, we're going to do an imaging study looking for the dilation of the superior ophthalmic vein. If we see that, we're going to perform a catheter angiogram, and there's some features on the catheter angiogram that are going to make it absolutely imperative that we discuss treatment, which is usually endovascular embolization with coil or onyx or other material, and those things are cortical venous drainage, pseudoaneurysm. Those are the things that we're going to push us to treatment. If they're losing their vision or they have severe pain, all those are also indications for doing a treatment. And so you should know that a carotid cavernous fistula is an arteriovenous fistula. It can present to us in ophthalmology as a red eye. You can also drain posteriorly into the petrosal sinus without draining into the superophthalmic vein, and that's going to produce a wide-eyed shunt, a painful progressive sixth is how that normally presents. So it can be a red-eyed shunt, a wide-eyed shunt, but all of these need imaging studies, and preferably the gold standard, a catheter angiogram.